Good evening and also good morning to some. I would like to first thank Dr. Fidel for allowing me to present today and also Dr. Sohail for this conference. Today I'm going to talk a little bit about diabetic neuropathy. This is a vast topic. There to be enough time, I will do a brief overview of diabetic neuropathy and some of the different things associated with this particular topic. Begin discussing some of the risk factors, the pathophysiology of diabetic neuropathy, and we'll also talk about some of the grading and classification systems that are present. So this is something that we need to identify and find different treatment modalities that will be successful in our patient. This particular slide here, you can see it shows the different amounts of percentages of incidence in diabetes that are found throughout the world. And if you look at this particular slide, you'll see that Egypt has approximately 12% incidence of diabetes. It's actually greater than 12%. The United States and India have a significant higher amount, which is between 9 and 12%. This is actually from the Diabetes Atlas, the 10th edition of the International Diabetes Federation. So one of the things that we need to take into consideration also is these are the different countries that are affected. And as you can see, China is the first country. It has the largest amount of diabetics. India, which is my country, where I'm from, actually has a significant incidence as well. It's number 2, and as you can see, number 4 is the United States, and Egypt has made the top 10. And by 2045, Egypt actually moves to the 9th position of diabetes. So these are very important things to keep in mind as the numbers continue to grow. Some of the risk factors that are associated with diabetic peripheral neuropathy, one of the main things that we need to
هو البرزنتيشن واقف دكتور فاضل؟
لا يا باشا.
complications that
كده اشتغل.
Okay.
The other risk factor of diabetic peripheral neuropathy is the duration of diabetes, damage to some of the blood vessels, not only within the body but within the nerves themselves, mechanical injury to the nerves, autoimmune factors, genetic susceptibility, and lifestyle factors which the patient can control, and we can help implement specific diets and smoking cessation programs. This will help. So as we continue along our pathway, these are some of the risk factors that are associated once again with diabetes and specifically diabetic peripheral neuropathy. And you can see with neuropathy, even the use of metformin can create small fiber neuropathy. So it's imperative that we supplement our patients with vitamin B12 because this can cause issues with vitamin B12 production and in turn a deficiency. Smoking is very, very important to help diminish with insulin resistance, and poor glycemic control, as we talked about, as the duration of diabetes will also affect diabetic neuropathy. And retinopathy, obviously, we understand how that may affect the eyes, and we get a decrease in HDL. The pathophysiology. So the hallmarks that are associated with the pathophysiology of diabetic peripheral neuropathy include microangiopathy of the vasonervorum, as well as loss of axons and axonal atrophy, and demyelination. So when you're performing an electromyography examination with a patient with long-standing diabetes, many times you'll see when the report comes back, you'll see that there is a significant amount of demyelination that is noted with a diabetic neuropath. So these are things that you want to take into consideration. This is a depiction of the vasonervorum. This is an irregular source of nutrition that supplies each peripheral nerve from the adjacent blood vessels. And as it supplies the nerve, it helps with helping to provide nutrients to the nerve itself. So this is very important to identify and make sure. And as we continue showing you the different types of atrophy that can happen with the blood supply, it's important to keep that in mind. So as the diabetes progresses and it affects, you can see from the top of this picture that the neuropathy progresses. And as the neuropathy progresses and you get diseased blood vessels, and also you get shrinking of the blood vessels, you'll see that the nerve, once the blood vessels disappear, will shrivel up. And so as this progresses, the symptoms will change throughout this course. This is another slide that shows the diabetic peripheral neuropathy and the healthy blood flow. And you can see here, as the nerves become damaged, you get occlusion of the vasonervorum, and you also get the myelinated as well as the unmyelinated fibers of the nerve are damaged with diabetic peripheral neuropathy. This is a depiction that was done in Diabetologia that shows this is a common peroneal nerve of a rat model, and it shows the control, and then on the right hand side it shows that the artery has significant decrease in size, and this is depicted in a rat model that had diabetic neuropathy. So this is important because blood flow is important for laying down of myelin as well as repair of the nerve. And the reason this is important, and I will show you in the next slide, is as we can see here, when you have a decreased amount of blood flow, the Schwann cell itself receives its nutrition from blood flow. And when the blood flow becomes obstructed, you also have either apoptosis of the Schwann cell, or you get the migration of the Schwann cell. And the Schwann cell is important in laying down myelin. So and the production of myelin. So once we don't have Schwann cells, then the myelin cannot be reproduced. And what that also does is it can increase the amount of shrinkage within the cell, as we showed previously. So as we move on, the different classifications of diabetic neuropathy can include symmetric polyneuropathy. You get autonomic polyneuropathy, as well as polyradiculopathy and mononeuropathy. These are all different types of neuropathies that you can find. It should all be noted that you want to identify and see if there's any diffuse or focal types of neuropathies as well. And more commonly with diabetes, as we progress on, you'll see different types of diffuse clinical neuropathy. These are usually symmetric, affecting the sensory motor and autonomic syndromes. The symmetric polyneuropathies this is most commonly the form of diabetic neuropathy, and the patient will experience a stocking and glove type of sensory loss. Also, you'll have different signs and symptoms that include pain, paresthesias, dysthesias, and loss of vibratory sensation is also noted in this type of loss. As we progress the pathogenesis of diabetic neuropathy, you have metabolic factors, then you have ischemia, as well as nerve fiber repair mechanism impairment. And so we have discussed ischemia and showing how the importance of blood vessels are for nerve health, and also the nerve fiber repair mechanisms become impaired because the Schwann cell is no longer able to repair and lay down myelin. So we've discussed that. Now we'll discuss some of the metabolic factors. And so some of the metabolic factors that affect diabetic peripheral neuropathy include high sugar that damages the nerves through multiple biological pathways that include activating the glycolytic pathway, the nerve, and Schwann cells that can lead to buildup of lactate and pyruvate within the nerve. You also get what's called dyslipidemia, and basically what dyslipidemia is the accumulation of abnormally high levels of fat in the blood, and this plays a major role in type 2 diabetics. You can also have oxidative stress which is caused by hyperglycemia and dyslipidemia, and this can lead to changes in the DNA of the patient, as well as damage to the endoplasmic reticulum, as well as stress, oxidative stress, and you get mitochondrial dysfunction also noted. You also have impaired omega-6 essential fatty acid metabolism that can lead to elevated oxidative stresses, and this all compounds and worsens the neuropathy over time. So this is a depiction of what happens as the nerve progresses in damage. You get both a chemical and an electrical disruption of the nerve. So as the glycemic variability continues to occur, this can contribute to axonal ion channel dysfunction, which is depicted here. And basically, with degeneration of the nerve, patients may have a predisposition to develop chronic inflammatory demyelinating polyneuropathy. And this can facilitate the formation of a diabetic foot hyperglycemia, which leads to shunting of excessive glucose through the activated polyol pathway. This disrupts the neural sodium potassium ATPase. This causes intraaxonal and sodium accumulation, which is depicted here. So you essentially get an increase in a positive charge within the nerve and an increase in the sodium. What happens is that as this pattern of change continues to occur, you get axonal depolarization and an abnormality that creates more of a dysfunction of the energy-dependent axonal sodium-potassium pump, and this can affect what's occurring within the nerve. So as we continue on, we'll discuss some of the motor dysfunctions of the peripheral diabetic neuropath. So as we have non-enzymatic glycation that occurs, this predisposes our bodies to ligaments that become stiff, and the neuropathy can also cause loss of protective sensation and loss of coordination of different muscles in the foot and the leg. This can increase the mechanical stresses during ambulation. So with motor dysfunctions of the peripheral nerve leading to diabetic neuropathy, we see that there is intrinsic pedal wasting. We also see with this intrinsic pedal wasting, we see overpowering of different parts of the muscles. So you get the intrinsic pedal muscles overpower the extrinsic muscles, which can result in hammer toes or claw toes. And then you can also have breakdown of skin and increase in deformities with these particular deformities that can create further complications of the foot. You also can have an autonomic dysfunction of the peripheral nerves, which could lead to pseudomotor dysfunction. And this you'll find will result in dry, cracked skin and an intrinsic minus foot, which is more prone to injury and breakdown. This will result in loss of sensation of the foot with repetitive stress. And with these repetitive stresses, you get structural deformities such as we discussed, such as hammer toes, bunions, metatarsal deformities, and this can further lead down to Charcot foot with further stresses and continued breakdown of tissue. So it's important that we identify the different types of dysfunctions and treat them as we move along. So there's the metabolic hypothesis of diabetic neuropathy is more of a chronic hyperglycemia, which causes damage to peripheral nerves through the various different pathways that are found in the body. One which involves an increase in the entry of polyol that is regulated by aldose reductase. What this does is the polyol pathway will create increase in damage to the nerve. Another theory suggests that there could be what's called advanced glycation and the production of end products, and this can produce injury to the endoneurium of the nerve itself. And as you can see in this slide, the depiction, you can see as hyperglycemia increases, the increase in glucose, and you get binding, and you can create what's called insulin resistance, and you get desensitized insulin receptors. So as this produces, you don't have any more sites for binding, so it increases the glucose extracellularly. In combination with increase in hyperglycemia and dyslipidemia, which creates more microvascular disorder. And this, in turn, will create a ligand-type receptor response. And you'll have injury to the mitochondria, you'll get dysfunction and oxidative stress, as we had already discussed. And this creates an inflammatory reaction within the body itself. This slide here depicts the pathway of pathogenesis of diabetic neuropathy, where we see the extracellularly increase in glucose, and you've got the dyslipidemia, the different receptor types, and what occurs intracellularly. In this side, it's important to the osmotic stress of the polyol pathway can create DNA damage and different stresses within the body. The other thing is the glycolysis and increase in inflammatory signals can create oxidative phosphorylation, which in turn affects the electron transport and can create mitochondrial dysfunction and possibly apoptosis. So these are important things to look at. As there's another theory that states that diabetic neuropathy can also be caused by an immune response by antiphospholipid antibodies, as well as autoantibodies and gangliosides. And this can exhibit different types of ischemias and injury. And as we continue on, the microvascular hypothesis of nerve ischemia with microvascular insufficiency, we have discussed this at length prior.
يا أهلا.
So neurotropic hypothesis. And so the neurotropic hypothesis of diabetic peripheral neuropathy states that there is a deficiency of different neurotrophic factors within the body. The first being the nerve growth factor, the neurotrophin 3, 4, 5 factors and insulin-like growth factors can all be injured and affected and diminished. So when we evaluate a patient for neuropathies, things that we look for are they focal neuropathies or are they diffuse neuropathies? So this is important for us to identify. And you should note that diffuse neuropathies are specifically motor and sensory symptoms, and this will help to identify. It's important to identify the different nerves that may be causing the diffuse neuropathies. So when a patient has acute painful neuropathy, and so it's been going on for less than 6 months, and it's moderate to severe pain, that includes burning, stabbing, tingling, pins and needles, paresthesias, or prick-like sensations, and the patient has pain that's elicited more at night, more nocturnal type pain, it's important for us to identify what could be the causes of this, or what could be the differential diagnosis. Many a times, due to the nocturnal pain, the patient will have sleep disturbances. So when the patient has acute painful neuropathy, it's important to rule out insulin neuritis, rapid correction of blood glucose levels, chronic alcohol consumption, associated amyloidosis, as well as multiple myeloma, HIV, possible heavy metal poisoning such as arsenic, and Fabry's disease. So these are important things to rule out. When a patient has chronic painful neuropathy, usually moderate to severe pain that's greater than 6 months, and it's somebody that's had long-standing diabetes for several years. And it's important to note that initially they may have a significant amount of pain and discomfort, but as the nerve diminishes and atrophies, as we've seen, you get loss of pain over time, so they'll just have numbness. It's important to evaluate each patient, and when taken into consideration any type of neuropathy, including diabetic neuropathy, we should first identify if there's any muscle weakness. So we grade the muscles from 0 out of 5 to 5 out of 5, and you should identify from the upper legs to the lower legs to identify different areas that could be weak. Other things that we want to watch for when assessing is muscle cramps. Many of the patients will exhibit different cramping. Most likely they're prominent nocturnally. They'll have a prickling or a numbness pain. You also want to identify if they have any type of GI symptoms that can be created, poor bladder control and sexual dysfunction. So when I evaluate a patient for diabetic neuropathy, I use multiple different tools. One, again, I'm identifying using vibratory sensation. I'm also using a reflex hammer, and I'm using it to percuss different areas of possible entrapment. One of the areas that is missed and not identified many times is the superficial femoral cutaneous nerve on the lateral aspect of the thigh. It's important to go ahead and percuss this area and identify if there may be any entrapment in this area. Many times when we treat the neuropathy, we also treat this nerve because it can be entrapped. The other thing is we identify different patterns of sensations using a pinwheel, and the Semmes-Weinstein monofilament are important in also identifying different ways of assessing. Diagnostic evaluation of peripheral nerves. So there's a study that was performed that showed that in early stages of diabetic peripheral neuropathy, when ultrasounding the muscles, you'd be able to see that the intrinsic muscles will actually decrease in size, and you won't have any decrease in the extrinsics. So this is an important diagnostic modality. The other thing is an EMG, electromyography, as well as nerve conduction studies. So as I had pointed out earlier, it's important to identify, you get the hallmark of demyelination with electromyography. Now, the electromyography will also, if the neurologist or whoever is performing the device and they're well versed, may able to map out and give you a grading of whether it's mild, mild to moderate, moderate, or moderate to severe, or severe. And this will also help you with different treatment modalities. The corneal confocal microscope allows identification of unmyelinated axons in the cornea. And there are different pseudomotor functional devices that can also identify. And there's something that is called the pressure sensory specified device. And what this device does is it's an accurate testing of the lower extremity. It uses a computer, and it's able to detect different peripheral nerve threshold levels as well as nerve innervation density, which can reflect axonal degeneration. As a result, the pressure sensory device is able to identify pathologic changes in nerves at a subclinical level, and it's pain-free. And again, as we move through, this is a publication that shows the neuropathy can reduce foot strength and early, as well as a decrease of intrinsic muscles, not the intrinsic foot muscles. So once again, we can use ultrasound to identify if this is occurring. So this is a depiction of how cyclical and how Charcot arthropathy is affected, and it can create breakdown in inflammatory processes, and can be a sequela of uncontrolled diabetic peripheral neuropathy. This is another treatment algorithm for neuropathy as well as Charcot neuroarthropathy. So with treatments, first we need to set goals of treatment. And what are we looking for? We discuss this with the patient. Other treatment modalities include pharmacological treatments, and there are some different surgical interventions that can be implemented with patients that don't respond to conservative treatment or pharmacological treatments. One of the things that's important is that we should always make sure that the physical examination of the skin and the foot temperature should be identified, and we should try to combat any skin drying or cracking by using moisturizing creams after bathing and thoroughly drying the feet. So these are very important things to keep in mind. So for goals, we want to slow down the progression. And how do we do this? Well, the most important thing is glycemic control. As long as we're controlling glycemic and exercising, these things will help to slow down the progression of the neuropathy. The other thing is relief of pain, and that's important, and we can use this using pharmacological options. And more importantly, we want to manage any complications, such as we discussed hammer toes, claw toes, and other types of complications or foot deformities that may occur, and we want to restore function. So pharmacological treatments include capsaicin creams, and capsaicin is applied to the skin, and this will help to reduce pain sensations in some patients. Some of the side effects that may be caused by this treatment is a burning type of feeling because it is made of pepper, and some possible skin irritation. Alpha-lipoic acid, this can be found in some foods, and it's a powerful antioxidant, and this may also help to relieve some nerve pain symptoms as well. It's also important, acetylcarnitine, this nutrient is made naturally in our body. It's also available as a supplement, and this can also ease nerve pain in patients. Some other pharmacological treatments that are important are magnesium and vitamin D3. These are all important vitamins that can be also used in the treatment of diabetic peripheral neuropathy to help decrease our side effects. So different drug types are used. The specific anti-seizure drugs that are commonly used are pregabalin, also known as Lyrica, and gabapentin or Neurontin, and this can help decrease the amount of pain and discomfort. So one of the main things that we need to identify are these anti-seizure drugs do come with side effects that include drowsiness, dizziness, swelling in the hands and feet, and over time you'll require more and more medication to help with the pain and discomfort. The tricyclic, so different types of antidepressants. The tricyclic antidepressants, they also include side effects such as drowsiness with difficulty concentrating, dry mouth, constipation, and you have to be very careful with these because they may cause orthostatic hypertension, where when a patient comes from a laying or a sitting position, they may actually pass out. So the other type of antidepressant are serotonin and norepinephrine reuptake inhibitors, or SSRIs. These are medications such as Cymbalta. And many times you may be able to combine, if you're not getting enough, such as Cymbalta along with gabapentin, if the patient's symptoms require it. So these are very important to keep in mind and help with preventing the pain and discomfort. Other treatment modalities include transcutaneous electrical nerve stimulation, and this helps to prevent signals from reaching the brain. So the transcutaneous electrical device stimulation will send tiny electrical impulses to different specific nerve pathways through small electronic patches that are placed around specific nerves. Now, I use this as a first-line treatment in almost all of my patients that come in, and I try to isolate and placing the patches at the common peroneal nerve as well as the posterior tibial nerve and stimulating for about 30 minutes. And amazingly, I do have quite a bit of patients, greater than 50% of the patients see at least a 30 to 50% relief within 8 to 10 weeks using this method. Another method is acupuncture, and acupuncture can help relieve the pain, and it generally doesn't have any side effects. However, you need to keep in mind that you don't get immediate relief, and you may require several sessions in order for this to be successful. And another modality that's being used is laser therapy. So surgical intervention, there are different types of surgical interventions that can be performed for this condition, and one of them being nerve decompressions. The other is spinal cord stimulator implantation. This in the United States approximately 2 years ago became an indication for painful diabetic neuropathy. And also peripheral nerve stimulator implantation. You must have a patient that has painful diabetic neuropathy in order to use this device. So nerve decompressions. So Dr. Lee Dellen from Johns Hopkins is a pioneer in performing decompressions for diabetic neuropathy. And what he found is by identifying specifically the peroneal nerve as well as the posterior tibial nerve and decompressing these two nerves, it gave patients a decrease in their diabetic symptoms with increase in sensation and decrease in pain. He also found that performing triple nerve decompressions, he was able to help decrease the progression of Charcot. It has to be performed with early onset Charcot, and he decompressed using the common peroneal nerve as well as the posterior tibial nerve and the deep peroneal nerve at the level of the foot, were the nerves that he found gave him the best results. This is an implantation of a spinal cord stimulator that's placed. This also helps by helping to decrease the amount of electrical impulses coming down, and will help to decrease the pathway back to the brain so the patient won't sense different pain with neuropathy. And one of the things that I have started to do is I've started to use different techniques surgically by using and harvesting motor branches from the muscles that are adjacent to the nerves and doing an end-to-side implantation into the main nerves. So it's sort of a reverse TMR. And I've had very good results with it. And this is a patient that I had recently performed a procedure on.
Did a surgical intervention on the patient who had chronic pain as well as neuropathy from diabetes on her bilateral lower extremities. We did the right side, but she also had extreme restless leg syndrome. And since the surgery, the restless leg has none. She no longer has restless leg. And all of her feeling is back in her right foot. And her pain level now is
Maybe a 1?
1, and it used to be before?
Oh my gosh, like a 20.
Like a 20. Okay, excellent. Like a 20. Okay, excellent.
And this is the presentation. So thank you so much for your time, and thank you again. And hope to see everyone soon in Egypt, inshallah.